Thank you all for joining us for the 2024 Karen Young and Dr. John K. Niparko Endowed Lecture. Just like to say a few words about Karen Young and John Niparko. Here, I think now we've probably at about 4,000 patients in our cochlear implant program. And that all started with the work of Karen Young, John Niparko back in the early 90s when Johns Hopkins didn't have a cochlear implant program, and really nor did much of anywhere else in the US, just a few places. From the early days of that program, Karin was an instrumental contributor, helping to lead the audiology side of the program. And John Niparko, surgeon and principal investigator lead of the program, created what he called the Listening Center, and has recently been renamed the Johns Hopkins Cochlear Implant Center. And in my recent work, working to continue the center that he created, and then also working to develop a vestibular implant, I've often looked back to the work that Karin and John Niparko did in those early years. It's a huge lift, a huge effort to create from nothing a group of people who are experts in their field, and then create the systems and optimize the care delivery mechanisms that are needed to provide the excellent care that they provided over decades before John moved on to take a chairmanship position at USC. Unfortunately, both Karin and John are no longer with us, but we honor their memory and we honor the contributions that they have made to our department and to so many patients and to so many other practitioners throughout the world who have learned from the work that they've done. I think it's especially fitting that our speaker today is carrying on that tradition of a combined striving for clinical excellence, not only in his own practice, in his own group, but also scholastic productivity that has guided many other groups. I look often to Dr. Carlson's work when talking with residents or just when studying up what to do with a particularly complex case. He's one of the most prodigious authors in our field, and with that great quantity comes outstanding quality of work too. So I'm very pleased to host our speaker. And Dr. Carlson, could you switch over and share your slides from here?
All right, I'll try to bring it up here. Let me know if it shows okay. Let's play here. All right, is everything projecting okay?
That's perfect.
Well, thanks, Dr. Della Santina, and it's really good to see a lot of familiar faces, Dr. Carey and Ward and others. It's a huge honor to have this lecture, just knowing the legacy that comes with this professorship. So I'm very grateful for this opportunity. I'm going to talk about conducting multidisciplinary research and kind of weave in and out a couple of general topics, and then more specifically talk about, I don't want to say a research project or study, but more of a series of studies that tells that builds a story over time that is not finished and won't be finished for my career, and it will probably go on for a very long time. And that's how to best care for people with vestibular schwannomas. These lectureships are so important to be able to spread and cross-pollinate across centers, and so we owe it to a lot of these people who set up these opportunities for us. I remember interacting with John Niparko as a second-year resident. He came to Mayo Clinic and he gave a lecture on cochlear implants, and among his statement that burned into my you always thin the ear canal to get to the facial recess well. So I remember that very early on. He said it like 5 times in his lecture. But beyond that, he, some residents kind of determine very early on what path they're interested in. Other people take a while to get to become differentiated. But I knew pretty early on that I was interested in ears, and he actually put me as just an ad hoc reviewer for the journal Otology and Neurotology, which is our flagship journal, which I thought was really, really cool to have that opportunity. And then pretty quickly afterwards, just spontaneously, I got an email from him during my 4th year, and he said, you know what, you've reviewed a lot of papers. You should be on the editorial board. And to the best of my knowledge, it was unprompted. I don't know if Colin or somebody emailed them, but I thought it was really cool for him to think about learners, trainees, and things like that with such a respectful um, approach. And it was really cool for me to even get an email from him at that point, let alone be asked to participate in the journal. So just really cool. Mayo has it's also really fun for me to give this lecture because vestibular schwannomas are a key area of my interests. And so it's kind of funny for me to give a talk to what I would consider the birthplace of real good vestibular schwannoma surgery. I wouldn't say microsurgery because it wasn't microsurgery at the time, but Mayo, the Mayo brothers and Johns Hopkins have a longstanding history of collaborating and cross-pollinating in the clinical and research space. And you might recognize at least one person in this photo. On the bottom right is Harvey Cushing, who in the late 1800s did his training at Hopkins and went away for a year to work with Coker, who's in the middle behind everybody. Then came back to Hopkins, where he's on staff for a period of time, and really started paved the way for reducing mortality rates and treatment of vestibular schwannomas. And in the middle, below Coker, so sitting down in the middle, is William Mayo, and this just demonstrates the relationship early on. There's several other pictures I have of them sitting next to each other in a large group of people, indicating that they respected each other and worked together and collaborated quite a bit. This is just another example of a letter that was written back in previous days. It was people didn't have business cards, but you would give each other pictures of each other, and you have some sort of greeting on there. And so this was a letter that was sent by Harvey Cushing to demonstrate his friendship with Charlie Mayo. Harvey Cushing, among many things, was credited really for introducing the idea of a clinician scientist, somebody who's doesn't have a separate lab, but really looks at their clinical space and their operating theater as their laboratory space in an area for emergent innovation and improvement to very directly improve the lives of the patients they care for. So I don't have any financial disclosures or conflicts of interest. I just want to, my disclaimer is when I get really excited about stuff, I start talking louder and it sounds like I might be angry. I'm not angry, I'm very passionate. So just to get that out of the way. So we're going to talk about these three concepts, and I want us to look at these things not as separate things. You might, when you look in the literature, you'll often see these things kind of separated, but they are really interrelated in it, and they build on each other for this final concept that we're going to talk about, size threshold surveillance. And I think you can't understand this new concept without looking at in the context of disease epidemiology and natural history. And so I'll try to build a story over time. But just jumping into that, whenever a subspecialist gives a talk about a niche topic, usually the rest of the group who aren't involved in neurotology might start to, their eyes might glaze over, or they might start working on emails and everything else, just thinking, well, how is this going to apply to me? But I think that there's a lot of concepts in here that will resonate with everybody, and I hope to build that throughout the talk. And just a couple general concepts for things that I've kind of happened upon for nothing else but by dumb luck, but just things that have been really beneficial to me in my career in clinical research. And having a slide like this would, might suggest that I feel like I have a good command of succeeding in clinical research, and I feel like I have a lot of failures too, but just some things that I think are relevant and worthwhile. A lot of us feel like we don't have time for research, and we say our clinical load is too heavy. And we kind of look at research, education, and clinical care as separate silos. But I think the best clinician scientists are the people that understand how that they are enfolded in, they blur together, and there's not one start or stop of one or the other. And just as Harvey Cushing said, really, our laboratory space is our clinic and is our operating theater. And if you think about it that way, you actually have a lot of time for research amidst your clinical care. And most importantly, because of your experience, you have the right questions you can ask, listening to patients, and also identifying gaps and knowledge gaps and data gaps that you can try to bridge in research. Mayo Clinic became famous on the back of the concept of integrated multidisciplinary care, the idea that you would see one clinician, you would go down the hall and they would get your medical record, and another person would review it, and collectively would come together to determine the best course or recommendation for the patient. And I think you could take all of these early statements or these Mayo axisms and you could just plug in research where you said clinical care and it would still be true. And it's just this concept that we are all, we don't have the bandwidth, but also the cognitive capacity to do all areas of all aspects of a clinical project well by ourselves. And the more we work with people collaboratively across disciplines, but also supportive groups like statisticians, we'll have better outcomes for our patients, not just from a bandwidth standpoint, but also from an expertise standpoint. And so some of the best things I've done is collaborating with my neurosurgery colleagues, other clinicians, supportive clinician groups such as radiologists, pathologists. And I have one statistician that I work with all the time, and she is super helpful. She knows the disease, there's no onboarding, and she makes all our projects very efficient because she knows all the language, she has great literacy on the topics, and just makes it flow so much more seamlessly. Just another concept is this idea that oftentimes when we're involved in projects, we often say, well, what's in it for me? I'm busy, so I have to balance all the things I'm doing. And if it's not a great help to me, I can't put my time into this. Life's not about just finding good things to do. It's balancing the best things to do, and because you don't have time for everything. But I want to bring out this concept that don't think about a single project, getting what you deserve on a single project, being first author or something else, whatever you want to say. Think big picture, long term, and the more your team succeeds, the more you succeed. And don't think of your team just narrow niched like a group of 4 or 5 people in your lab. Think about your department, your other people you're operating with, and everything else. You bring in more wealth of knowledge that naturally leads into more projects and more where everybody wins. You effectively make a larger pie. And expand your network. A lot of people, we all kind of feel like our immediate group is our laboratory, or people we collaborate with, but think beyond that, not just into your institution, but think across institutions. Some of the most fun work I've had is collaborating with groups outside our department and outside our institution. And it's just based on this idea that we have this kind of incorrect notion that everybody does things the way we do, across the United States, but internationally. And that's just not the case. There's so many different ways to skin a cat. And the more we collaborate, the more we all benefit from that collective knowledge pool. Develop and cultivate a tiered team structure in your lab. Be responsive, respectful, and loyal to everybody on all the different tiers. And like I said earlier, that was really incredible to me to have Niparko come back to me as a 4th-year resident and ask for me to be involved in his team and be on the editorial board. I thought that was amazing that he would have the time and respect to talk to somebody who is as lowly as a 4th-year resident. Another thing is responsiveness. This is something that when I talk about it here, it'll feel like it's overlooked or like so simple that why would you even bring it up? But if you think about the simplest project, a case report, or the most complex multi-institutional prospective randomized controlled study, there's a certain amount of communication that has to happen across everything, and whether it's emails or telephone calls. And just say for a larger study, it takes 500 emails to effectively carry out the research project. If everybody takes a week, or if everybody takes a day to respond, that changes the rate of your progress 7-fold. And I think just being responsive within a team dramatically improves the efficiency and output of the study. So it seems like a minor thing, but I feel like it's lost a lot. And then this is just kind of the segue or the springboard to jump into what we're going to talk about. But most importantly, one of my favorite movies is The Matrix, and they have this, interesting quote about unlearning the system to be able to see things for what they really are. So almost every system that we're involved in, you can think of any system, you can think of any clinical system, research system, or anything else. Most of it has developed from a series of problem solving and from internal and external pressures, but it really wasn't strategic over time. It was emergent and somewhat archaic and random. And if we rethink what we're doing now with some basic knowledge and context, but if we're not constrained with what we've learned, we'll often redesign things very, very different. Most of what we do isn't based on evidence, but we hold on to it so dogmatically, like it's black and white, but it's not. So think outside the box. Don't get too constrained by what you learned. I would say probably about half of what we think is to be complete absolute truth is not true, and we'll learn that later. So just for some context, we have a robust vestibular schwannoma program at Mayo Clinic. I'm a big history nut, and I look back at all of our surgical records and surgical notes dating back a very long time. And the first report I could find of documented surgical resection of what would be unequivocally be considered a vestibular schwannoma was in 1907. So maybe not quite the history of Hopkins, but it does go back pretty far. We have the third gamma knife unit installed in the United States in 1990. And I would say since 1980, we've had a very good collaborative relationship with otolaryngology and neurosurgery. Every single case we do together, even if it's a case that we do everything on, or it's a case they do everything on, we're still in there. We'll talk. It's not just having two hands in there, in one person's two hands in one head. It's having four hands and two brains and a discussion about things, especially on a longer case where you're at the end of the case and you just want to get things done. It's good to have that collaboration. We see about 200 new patients every year. So that's just some background and context. So now we're going to get into the story. And we're going to get into those three different topics, or I'd call them chapters, that we'll move through. The prevalence, incidence prevalence, so some epidemiology, and this is updated, not the Danish data, but updated for US data. And then secondly, we'll talk about updated data on natural history. And then lastly, those will serve as building blocks or cornerstones for the concept of size threshold surveillance. So when a person comes in and they're diagnosed with a vestibular schwannoma, they hear they have a brain tumor, which conjures ideas of incapacitation and death. And after you talk to them and tell them what it actually is, they'll and it's not malignant, and their chance of dying from it is very close to zero today. They ask questions like, well, how rare is this? And we'll always respond by saying, well, you won the bad luck Powerball. It's exceptionally rare. It's 1 per 100,000 people. That statement is based on data from pre-MRI era, and you're also quoting incidents, and they're actually asking a prevalence question. So the real prevalence, if you live to 70 in the United States, you have at least a 1 in 500 chance of acquiring a vestibular schwannoma. Some of this is based on, that data is based on the Rochester Epidemiology Project, which is a medical linkage system that was developed by a Mayo Clinic neurologist in 1966. And since 1966, every single medical care visit, whether at Mayo Clinic or another care center in Olmsted County, is captured with a 99.9% capture rate. And so in that way, anything that happens in Olmsted County from a medical standpoint is captured in this. And so it's an enclosed system. This doesn't include referrals in. So this is really, residents of Olmsted County and looking at their epidemiological data over time. So just, I want to separate the concepts of incidence and prevalence. A lot of us know what it is, but some of us get it confused a lot. And they're really important differences for something like vestibular schwannoma. So incidence is the number of new cases per unit for a given time frame. And prevalence is cross-sectionally the number of people that have that condition at any given time. So that snapshot in time. And for diseases that you can cure easily or you die from quickly, the prevalence and incidence are similar. But for diseases that aggregate or build up in the population, the prevalence becomes much higher than the incidence over time. So if you think about a condition such as something that's highly lethal, so a grade 4 GBM or pancreatic cancer or something else like that, where you have a high mortality rate, your incidence and prevalence are similar. But if you think of rheumatoid arthritis, most people don't die from that right away or sometimes ever. And so a lot of the prevalence becomes much higher. Most people with a vestibular schwannoma don't undergo immediate surgical resection. And so you accumulate a large number of people who are wait and scan. And I would consider even radiosurgery is not a cure. And then they retain their tumor. And so the numbers increase over time. But basically, in our data, our incidence rate is about, in the population of 60 to 70-year-olds, is about 10 to 25 people, cases per 100,000 people per year. So about 25 times those old rates that are quoted. Then if you look at prevalence, the number of people that are accumulating in the cross-sectionally in the population, if you do the math and you lower it down to a lowest common denominator of 1, it actually becomes 1 in 500 if you live to over the age of 70, or 1 in 2,000 adults at large. So a lot more common. This data is a little bit skewed from the perspective of, in Mayo Clinic, we have about almost 50 MRI scanners. In the Olmsted population is about 140,000. So I think we probably have the highest ratio of MRI scanners to populace in the entire world. We're surrounded by farm country, and we have a lot of magnets. But that also includes a number of people that weren't actually scanned. So I think it's, it's true. It doesn't approach the old numbers that were in the late 1800 and early 1900 cadaver studies by Crow and others, where it was like 1% of people, but we're approaching that. And so it is more common than we previously thought. And what's interesting is the demographic is changing significantly. So how we talk about vestibular schwannomas and how we manage them should be very different from 30 years ago, because the population, the disease is completely different than it was 30 years ago. Most tumors are pretty small. Most people have minimal symptoms. And actually, paradoxically, you'd think if you were diagnosing that at earlier age or earlier in disease, you'd have an earlier age, but because of the aging population demographic and because of more scans being done in older people, the demographic is actually changing. More people who are older are being diagnosed than younger compared to decades earlier. So older people with less symptoms, often incidentally with small tumors. And actually, in Olmsted County right now, if you reside in Olmsted County, you're more likely to be diagnosed with a vestibular schwannoma than you are with otosclerosis even. And which is quite remarkable, because otosclerosis used to be extremely prevalent, but we know that the prevalence of that disease has gone down. And as I've marked, the vestibular schwannoma prevalence is increasing. It's not crazy to think that this could be happening. Obviously, we have other parallels in other disease processes, such as HPV-related oropharyngeal carcinoma. The drivers of lower prevalence of otosclerosis and higher prevalence of vestibular schwannoma aren't completely known. Most people would say that the greater prevalence of vestibular schwannoma is just secondary to more scanners. I always jokingly say the number one risk factor for vestibular schwannoma is an MRI, because that's the only way you get diagnosed. But even aside from that, if you look at the rate at which we're scanning people, the prevalence of vestibular schwannoma is actually increasing steadily beyond that. So there's probably other factors besides just detection. So that's the first chapter. You know, if we're lucky, people remember one thing from a talk. So I have 3 chapters. So the first thing to remember from the first thing is they're a lot more common than they used to be, and it's about 1 in 500 when a patient asks the question. Second chapter is patterns of growth in natural history. The golden rule of skull base is, and it should be all of surgery, is never do more harm to the patient than what's expected of the disease over the person's anticipated lifetime. And so putting that in the context of vestibular schwannoma, 30 or 40 years ago, we always thought that vestibular schwannomas were associated with significant morbidity and ultimate mortality. And so basically every tumor came out and it was treated like a cancer. If you couldn't get it off the facial nerve, you'd take the facial nerve with it. The Danish data was quite disruptive in the sense that they had pretty robust data from their registry of where they capture almost every single patient in Denmark, in the Copenhagen, where everybody's care is centralized by a central team, and they have a registry since 1976. They've been following people, and the data that I'm showing here is from that. And when they presented it, it was quite eye-opening. And they said that basically 1 in 5 tumors, only 1 in 5 tumors in the IAC actually grow after detection, and only about 1 in 3 of extramatal tumors grow. There's some issues with that. It's not the experience we have in the US, and part of that's referral bias. They're seeing everybody. Bigger centers are seeing people after they've been referred, after there's been growth, or the tumor's bigger, they have more symptoms. But also the Danish data was about a third of it, in particular the early on data, was based on CT. And so you can't see growth. You can't even detect a tumor that's less than 1 centimeter in most cases on a good CT scan with contrast even. So how are you going to detect tumor growth of 2 millimeters or 4 millimeters? Of course you can't. And in their definition, they said growth was determined for an intramatal tumor. It actually had to sprout into the angle to be considered growing. So if your tumor was 2 millimeters and it grew to 6 millimeters and stayed in the IC, it wasn't counting growth. It wasn't counted as growth, even though all of us would count that as a growing tumor. So just some differences there. The devil's in the details. If you look at US data and you look at linear growth measured by at least 2 millimeters in maximum dimension, and then volumetric growth, the noise floor being about 20% threshold for being true volumetric growth. And then treatment and a Kaplan-Meier time to event analysis. At 5 years, about half of tumors have linear growth detected. About half of those are treated, and about 70% of tumors demonstrate volumetric growth, which is pretty interesting. A lot of people, when you start talking about volumes for vestibular schwannomas, they start eye rolling and they say, well, if I can't see it on linear growth, but you can detect it on volumetric growth, it's not clinically significant. And I'd agree with that statement largely, except for 2 areas. The first is for NF2, it's really valuable to have volumetric growth because the tumors are nodular and the single dimension is really inadequate. And secondly, there's a lot of collision tumors that occur in NF2. And so you have all these tumors together as a conglomerate, and volumes are much more accurate for that group. But the other thing is when you're trying to study anything that's very, very slow growing, if you want to do it well, you have to do one of two things. You either have to follow it for a very, very long time to detect changes, so 10 or 20 years, which is not practical, or you have to have a more sensitive measure of change. And that's what volumes does for you. It's a much more sensitive measure of change. And so in a shorter time interval, you can determine differences in growth than you can with linear. So just that side note. If we look in the US, we did a single institutional linear measurement and volumetric measurement, and then we also did a multi-institutional study, including 3 or 4 other large centers, and several interesting things came from it. The first is that the tumor growth in vestibular schwannoma is erratic, and we call it saltatory. So they can grow and they can stop. They can be quiescent for a period of time and then accelerate rapidly. They can even shrink in a small percentage of cases. And even though they shrink, it doesn't mean that they won't grow again later on. We can naturally, intuitively arrive at this conclusion just based on the notion that we know some tumors don't grow right after diagnosis, but they grew to that point to begin with. And so naturally, we know a tumor can grow and then stop. But what's remarkable is they can grow and stop, and they can grow at different rates. And so with that large cohort of people, of 952 people that were measured with volumetric analysis encompassing over 4,000 MRI scans, so not a small study, we took a cohort of selected people who continue to observe their tumor despite documented growth. So most of the time, if there's growth, in particular if there's substantial growth, a lot of people will undergo some sort of treatment. But in the group that didn't undergo treatment, either because they're older, they refused to, they were lost to follow-up initially, or something else, we continued to watch a subset of people who had growing tumors. What's really interesting is that, so these are Kaplan-Meier plots for time to detection of growth. And what you'll see is that the first time growth was detected and the subsequent time growth was detected and the subsequent time growth was detected for each individual person, these plots are completely identical. Like they overlap each other perfectly, which is kind of the eureka moment. Like there's nothing special about the first time they're diagnosed. You just happen to get the MRI then for whatever reason, because it was their third time they had a sudden hearing loss and somebody finally decided to get the MRI scan. Or they had they were in a study on studying aging of the brain and they got an MRI scan and then they got their tumor diagnosed. But it's just to say that if you find a tumor and it's 5 millimeters and then it grows at that time point, it was growing for a long time. It was already growing for a couple of years before that. So why do you have to jump on it the first time you see growth? I mean, we can naturally come to that conclusion from seeing this plot here. And this is just a figure that just shows how random we treat patients. Patients can have completely different outcomes depending on when they were diagnosed, even with a small tumor in their pathway, and have completely different outcomes. So that's the second chapter. The first chapter is they're much more common than they used to be in older patients with smaller tumors and less symptoms. The second chapter is most tumors grow. All tumors necessarily grew. We can't predict which ones are going to grow and which ones aren't, but they can grow and stop growing. Interestingly, it's a very different from how we used to think about them, I think. So the last chapter of this is what we call the paradox of the wait and scan approach. So most of the time, most of us think that if a person decides to start a wait and scan or observational approach to their tumor, you'll follow it until it demonstrates growth. And then you'll say, you know what, you've had growth. We should treat it now because it's going to continue to grow, with the suggestion that growth is linear, which it's not. And based on the notion that your best outcome is treating it when it's smaller, which is probably a true statement. We'll talk about that a little bit more later, though. So that's the old paradigm. But if you look at it in the context, with some of the information we know now, we could say that all tumors necessarily grow at some point during a person's lifetime because they weren't born with it. Most tumors actually grow following diagnosis, but they might have interspersed periods of quiescence. There's nothing special about the date they were diagnosed or the initial detection of growth. And another concept is 2 millimeters or 4 millimeters growth is not going to change your outcome. I don't think there's anybody that can present any meaningful data that says if you intervene on a 4 millimeter tumor or an 8 millimeter tumor, you're changing their outcome significantly, whether it's observation, microsurgery, or radiosurgery on a population level. There are individual examples in special situations, but on a population level, I think that almost everybody who manages these patients would agree with those statements. But 2 centimeters would matter. So where's that tipping point in size? This just shows that there's this interesting way you can think about how we're managing patients now. So we commonly think of ourselves as enlightened. We know that we can observe a lot of these tumors, and we're doing much better than we used to do, right? So we're observing more tumors. So what's interesting is a greater proportion of people are being allocated to observation. So a greater ratio of people are being allocated to initial observation. But if you look at the percentage, the actual prevalence of treatment, we're actually treating the same number of people as we ever have. Said another way, the rate at which we're willing to be conservative over time is outpaced by the rate that we're detecting things more. And so if you actually look at the data, we're actually treating more people per population with smaller tumors and less symptoms than we ever have in the history of vestibular schwannoma, which is interesting. It's the opposite of what we might conclude. But if you look at the prevalence of treatment, and you look at it in that context, we're actually no more conservative. In fact, you could argue that we're potentially even more aggressive than we have ever had before. And this is just, I think this drives home that point. And so in the pre-MRI era, there were a lot of people walking around with tumors that never knew they had it, and they died being all the better off not knowing they had it from some other cause later in their life. But if they were diagnosed, they were almost always treated. In the post-MRI era, we're certainly not detecting all of them. There's a lot of people walking around that don't know they have them, but we're detecting more of them. And even though more people are being observed, if you count the number of red dots in both of those, they're the same. We're not actually more conservative, even though we'd like to think we are. And what's interesting is, vestibular schwannoma it's not like a rhinoplasty where you're making a person look better or you're making them breathe better. It's all you're trying to do is prevent downstream complications, usually, especially for small, medium-sized tumors. You don't make them happier, usually. You don't make them younger. You don't make them prettier. All you're doing is you're trying to prevent complications. The best you can do in most situations is maintain quality of life. There are exceptions, but in general, you're maintaining at best their condition and not improving it. And this is just some quality of life data to point that out. Like on a large patient level, if you follow people prospectively, our ability to change a person's quality of life before and after treatment is pretty limited. Like the average change on a large population of people on a 100-point scale is between 0.1 and 1.1 on a 100-point scale, which is nothing, meaning the patients and what they come in with are the greatest determinants of quality of life, and not what we do to them, as long as we're providing reasonable care for them. There's also this idea that maybe there's a group of people that gain benefit from having their tumor removed from a general quality of life standpoint. But if you look at a patient's global satisfaction with treatment, whether they had microsurgery or radiosurgery or observation, the people that had observation have a 96% chance saying, in hindsight, knowing what I know now, I'm satisfied with my decision to pursue observation, versus only about 85 or 86% of people with microsurgery and radiosurgery. So those two groups have a higher decisional regret, even though importantly, most people are still satisfied with their treatment overall. And if you collapse the radiosurgery and microsurgery groups together, because they have similar numbers, 85 and 86%, you can almost see this like dose-dependent change. The closer you get to observation, the more satisfied they are. So if you have upfront treatment with microsurgery or radiosurgery, 19% of people were not happy with their choice in hindsight. If they observed their tumor and went on to treatment, presumably for growth, but there could be other reasons, they had an 88% chance of being happy and a 12% chance of being unsatisfied. But if they could continue on an observational course, 96% of people were happy and 4% of people were unhappy. And you can poke at this. There's a lot of holes in it, I'm sure, based on selection bias and things like that. But it's an interesting finding that if you can start with observation, you can maintain it, you're most likely to be happy long-term on a population level. There are examples on the individual level. So putting those three things together, all tumors grew and most grow if treatment doesn't improve outcomes, and there is evidence of ongoing overtreatment, then we probably shouldn't be treating tumors based on the finding of whether they're growing or not, but we probably should just use a size threshold. Like after they get to a certain size, then you should start intervening on them more than anything else. So what is that tipping point? We said earlier, if your tumor is 4 millimeters and it grows to 8 millimeters, your outcome is going to be the same for microsurgery and radiosurgery. If you treat them at those two different size points, but if they're 2 centimeters bigger, your outcome is going to change on a population level very clearly for all those modalities, actually. So where's that tipping point? We looked at a population of about 600 patients, or a cohort of 600 patients, and we tried to find out where that accelerated rate of an adverse outcome or poorer outcome happens based on size, because size is the #1 predictor of worse outcome for all these things. So ability to achieve immediate House-Brackman 1 or long-term House-Brackman 1, or ability to save hearing, or ability to perform complete resection. And for a CN index curve, that inflection point or the peak is that tipping point of accelerated poorer outcome. And if you look at that, the tipping point really aligns around 1.4 to 2 centimeters in the angle. So people measure vestibular schwannomas many different ways. The way we're reporting it here is maximum CPA diameter. So basically, based on this data, we think there's reasonable information to suggest that once a tumor starts approaching about 1.5 centimeters in the angle, then your outcomes are starting to deteriorate, and you should consider recommending treatment if you've been watching a growing tumor over time. And what's really fun is when you have data, so this is kind of a conclusion that a lot of us have reached just based on clinical grounds. Like most of us say, once it's touching the brainstem or something like that, we start thinking about treatment and not observing it, for example. And this actually shows that validates that clinical intuition. It's nice when they both align, which I think this does based on most people's clinical intuition and position. So that's microsurgery. What about radiosurgery? The tipping point for radiosurgery is a little bit more, it's a little bit more of a feathered edge, or it's a little bit more gradual, meaning it's hard to detect small differences between 1 centimeter and 2 centimeters with radiosurgery. But one thing that's often overlooked, I think, for radiosurgery is building in the risk of failure and the outcome from that. So like if you have microsurgery and you get radiosurgery afterwards, the added risk is very, very little. So it's not harder to do radiosurgery after prior microsurgery usually, but it is more difficult to do microsurgery after prior radiosurgery. So it's not equal both directions. And built into radiosurgery treatment journey is a 10% rate of failure at 10 years. Most series would say something like that. Some report better, some report worse, but around 10% of tumors continue to grow after receiving radiosurgery if you follow people out at least 10 years. If you have a tumor that failed radiosurgery, there's a 50% chance that you don't walk away with either gross total resection or a good facial nerve outcome. And I say those are two sides of the same coin. You choose which one you want if your tumor is bigger, but you don't get both on a bigger tumor or even a medium-sized tumor a lot of the time. So all of that to say that even with radiosurgery, I wouldn't watch a tumor that's 1 centimeter grow to 2 centimeters because the outcome with radiosurgery is the same. I also think, like, what if it fails? I don't want to operate on a tumor when it's 2 centimeters and failed radiosurgery. I'd much rather operate on a 1 centimeter tumor that failed radiosurgery, because you can have a pretty good surgical outcome still in that smaller tumor size category. But the story of radiosurgery and that tipping point size is yet to be determined. We have a couple studies that we hope will help determine that threshold a little bit better. So this is what it's all about. A lot of people would walk away from the first part of the talk saying, oh, if you go to Mayo Clinic, they're just going to watch every tumor until it becomes 1.5 centimeters and then take it out or radiate it or whatever. That's not what I'm saying at all. What I'm trying to show is that this allows you to think about it more flexibly and align your recommendations with what the patient wants through shared decision making. So you don't have to think so dogmatically, like it's 4 millimeters and it grew to 1 centimeter in the IAC and they still have good hearing. And they ask the question, well, why do I have to treat it now? And you'll say, well, it's going to continue to grow. You actually don't know that, and you don't know when, and you don't know the outcome. So it allows you to more flexibly take care of patients to meet their goals. So this is how it could play out. You have a patient that comes in with a small tumor, and you initially, and they decide to undergo observation. So you observe their tumor. Instead of treating it right away, this data would either, if you knew that most tumors grow, you'd either say, well, you should treat it right up front, or you can tolerate some growth. If you believe that we're overtreating tumors, you would favor tolerating some growth. So this is an example of a patient that might fit this, what we do. So a small intracanalicular tumor in an older patient with good hearing. Over 2 years' time, it grew a little bit more. Instead of treating it right away, you can continue to watch it. This patient's hearing was still maintained at that level during that time. Outcomes with vestibular schwannoma are not hearing preservation or not hearing preservation, good facial nerve outcome or not facial nerve outcome, tumor recurrence or not. It's about maximizing the duration of time you afford a patient that functional status. So even if they can lose their hearing, if you could delay it 10 years, and if they're 70, that's a lot of their remaining lifetime, and that's a win. And so it's not this dichotomous or binary, you saved it or you didn't. It's preserving it for as long as you can. So in line with that, just this concept of using a size threshold rather than just detecting growth on 1 or 2 scans as a trigger for treatment. This approach will probably reduce over-treatment. It's also nice to see what the tumor is doing over time a little bit because it defines the tumor behavior. There are actually some data that says if a tumor grows really rapidly, it might be less responsive to radiosurgery, and you'd never know that if you treat it with radiosurgery right away until it was too late, because you already treated and then you have a failure on your hands. You also improve patient acceptance. There's good quality of life data to indicate that the worst point on a patient's vestibular schwannoma clinical journey is the day they were diagnosed with the tumor. Not the next day after they wake up from their surgery, even though they felt like a train hit them. It's that first time you're told you're diagnosed with a brain tumor. And after you can settle in the diagnosis and you realize it's not going to kill you, your quality of life could improve again. There's this idea of physiological compensation. Netterville gives these great talks about how it's better to take out a glomus tumor after the person's lost their function as a result of the tumor and not you going in there and cutting the nerve abruptly. I think the same thing is actually true for hearing loss. Like, we don't talk about it that way, but if a person immediately loses their hearing from a sudden hearing loss or a surgery, it bothers them a lot more than a person who lost it slowly over decades or many years. So even though you might end up at the same state, I think the way they feel about it and they compensate from it are very different. Then lastly, it builds rapport and trust. Even if you're going to end up operating or offering radiosurgery for a lot of these people, it's just kind of frame shifted down the road, but you get all these added benefits in the middle. Longer time with certain function, building a rapport, greater patient acceptance, and reducing overtreatment. So in conclusion, vestibular schwannomas aren't rare. I wouldn't call them common either. Actually, technically, according to legal definition, they're no longer a rare disease. I don't bring that up because sometimes I don't bring that up a lot because it sometimes removes our ability to get rare disease designation for funding, but it technically isn't anymore. All vestibular schwannomas necessarily grow, because people aren't born with them, and most continue to grow. There's nothing magical about the date of diagnosis or the first time you detect growth. It's been doing that for a long time, unbeknownst to the patient and to us. And despite being more conservative, we're actually treating smaller tumors in people with less symptoms than we ever have before. Consider a flexible treatment trigger. You don't have to observe every tumor. A person might come in and say, I just want it out. I've thought about it, and you've given all the information they wanted out. That's fine. But you should also use this knowledge to allow for a flexible treatment trigger for the patient that would benefit from using this new knowledge or new way to think about it. And don't settle for because it's the way it's always been done. Try to think outside the box. And that concludes everything. I want to make the point that the way I'm presenting this might suggest that I'm claiming that this was my idea. A couple of things. A lot of people have been observing growing tumors for a period of time. So this isn't a new concept. I'm just putting data behind it to support the idea and show that, to actually define where that threshold might be. So I'm not claiming originality, but I'm just giving data to support what some people have been doing all along. But that's a conclusion of my talk, and I'd be grateful to answer any questions.
Fantastic. Thanks very much, Dr. Carlson. I've got questions, but I tend to talk too much in meetings, so I'm going to be quiet at first anyway. Does anyone else have a question to pose?
I'm not offended. This is the end of Monday, so.
Okay, well, I've got questions. One thing that jumps out, a couple of things. One is when you mentioned using tumor size as a threshold rather than tumor growth. The size that you specifically were plotting is the size of the CP angle component, which makes me wonder, does the part of the tumor in the internal enteric canal not factor into the decision making in your view?
I think the biggest thing is that this is one small additional piece of information that fits into the greater decision-making process. And so there's so many variables that can feed into it. Like, so if a patient starts with observation, I think if it's growing in the angle, you can tolerate some growth. There's so many factors that weigh into it. So the intracanalicular portion and the fundal cap in the patient's hearing and all those things are factored into the whole decision process. The reason we measure, the reason we report it that way is not because the IC portion doesn't matter or anything like that, but that's actually the recommended way to measure them. That's how most studies measure them. One of the problems with measuring vestibular schwannomas is according to the recommended guidelines. So there's the 95 guidelines, and it was reinforced by the 2003 Tokyo guideline for measuring vestibular schwannomas. You measure the maximum CPA diameter, or you measure the two perpendicular parts of the CPA. You don't measure the IC part. And then IC tumors, you only measure maximum diameter. If a tumor grows, so that creates two different groups of people, and you can't compare them statistically. And the other problem is if you have an IC tumor that grows into the CPA, it's really challenging to use. You can't use it as a continuous size scale, which really impacts your ability to run an analysis. That's why volumes is better, because it doesn't matter where it is. You just measure the whole volume.
John Russell, I see you've got a question. Do you want to join audio?
Yeah, thanks, Dr. Carlson. Thanks, great lecture. Lots of parallels as you were talking about schwannomas with thyroid tumors, a lot of these small thyroid cancers. And so what advice would you give a surgeon who's maybe in a different part of the head and neck, but managing similar tumor trajectories with anxious patients? And what do you do to get the best quality of life in those patients?
Yeah, it's a good question. I mean, there's so many parallels. I have, just because I don't have time, but I have multiple slides that show many other diseases. You know, the idea is that most men die with prostate cancer, but don't die from prostate cancer. It's the same idea. Like, these are common disorders. Vestibular schwannomas aren't common, but not rare. Papillary thyroid, carcinoma is relatively common. And if you treat everyone, you're gonna introduce a lot of cost and morbidity from the treatment. But there is papillary thyroid carcinoma is a little bit different because you're looking at a thyroid nodule also, and just the probability of a thyroid nodule actually harboring, a carcinoma versus not, which is a little bit different than a vestibular schwannoma. But just the idea that, and this is increasingly important because of the number of scans and the sensitivity of scanners, we need to find out what patients need to be treated and which ones don't. And that's the $1 million question. There's so many things diagnosed. If all of us get a scan right now, every one of us will have one or two disorders, and it will lead to 4 or 5 other tests, and you'll get a complication from 1 or 2 of those things. And then in the end, you may not need it. Maybe you didn't even need it treated. I mean, there's so many different ways you could go with this. Like, maybe we should only scan people with a CT scanner, because then you won't detect the small ones. I'm not saying that's a true statement, but it's kind of tongue in cheek. It's funny. It's like, where do you go with this? Are we getting too sensitive? We need to find out, are our tests getting way too sensitive? Are we scanning people for every single, indication now? What to do with an incidental or a small lesion is the $1 million question in this era. It's not detection.
Thank you.
Jenny Chen.
Hi, Dr. Carlson. Thank you for that talk. I'm really interested in your work on the incidence and prevalence of vestibular schwannomas, and I know.
I lost Jenny.
Sorry about that. I think I'm back. Sorry, I just actually muted myself. My question was about your perception of the incidence and prevalence for non-Caucasian populations. I know there was a systematic review that you were part of a little while back that included some data from like Taiwan, but I'm never really sure how to counsel patients from like Asian patients or or patients from ethnic minorities on what you think are the actual incidence and prevalence for them. Do you think it's different, or do you think I can use the data from Western and Scandinavian countries?
Yeah, super great question, because everybody in Minnesota is from Scandinavia, and so we're, the big Danish population, and then our study we're very homogeneous actually, so it makes it challenging. My belief from looking at a lot of different studies and hearing talks about it is that the true prep, like if you did autopsies on 1,000 unselected people at the same age, that they would be very similar across groups. I can't prove that, but that's my feeling. I feel like that, when you look at SEER reporting and all this other reporting, and they say that they're most common in Caucasian people, I think that's, that data is based on a couple problems. The first is there can be cultural differences within groups and their, threshold for seeking medical care. There can be inequitable access to medical care, and then there can be biases on our willingness as physicians to treat everybody the same. And so those three, and probably many other things I don't know about, are influencing that. It's a great question. We don't know what we don't know. So maybe in the future we'll have better data. My feeling is they're relatively similar, but I think that they're disparate based on those issues. But time will tell with better research.
Dr. Ward?
Great talk, Matt, and I always really enjoy your talks. I have changed my counseling about these patients so much after watching these, so I have a follow-up from the prior talks, which is that patients always ask, "What would you do, doc?" And I often say, I don't like to answer that question. I would say that everybody has a different personality. I usually cite my mother, who would say, "Get that tumor out," even if it's like a 2 millimeter tumor. But I'm curious, based on that slide about regret, patients that are like that have high anxiety levels, do they regret their decisions more?
There's an interesting, and I just didn't have time to get into it, but there's an interesting subset of patients that are paralyzed by the idea of having a tumor in their head, and whether it's because of people around them, family feeding into this, whether they had a family member who died of a completely different type of cancer, brain tumor or something like that, or maybe themselves had a different type of tumor and they don't want a tumor in their body. There's a lot of different examples of that, but there's a certain population of people where surgery actually improves the mental health domain in the pan-qual. That's actually the only category for small to medium-sized tumors that budges in any subset. It's there's a proportion of people who have smaller tumors that just want it out, and they can sleep better and they don't think about it anymore. And so that's an example of a subgroup population where you can't look at, you can't look at the whole data set and say that applies to everybody. It's on an individual basis. I would suspect, and this is anecdote, but I would suspect that the selected group of people that went into it to have it out, if they can have it out, are going to be satisfied with their treatment. But I'm not old, but the more I do this and the older I am, I actually, when people ask that question, I used to just say, I can't give you an answer because everybody's decision is different. Everyone's different. And I don't know you very well. I give all those answers. Now I kind of answer it differently. I say, if there were 100 people like you at your age that came in with your condition, this would be the split of what most people would do. So I give them some context for what a common response would be. And I say each person's different. And if I do think there's a pretty strong, if there's pretty good data to suggest one thing, I'm more likely to say it now, but I don't push them into it. I tell them that, the other options are still pretty reasonable. And then there, in Rochester, we have a number of just local farmers, and they usually just want you to tell them what to do. That's a big generalization. I don't want to generalize, but it's very common. There is a group of people that just want you to tell them what they want. They're not the person who's had 6 second opinions. They're coming in for one opinion, and they want you to give them, your best recommendation. They'll follow it. And that's why it's important to be responsible with that, because that group is particularly susceptible to our bias because they're not getting additional information, looking around and gathering all the information themselves. They're going to jump into what you tell them, and they can be easily misguided. But yeah, interesting, a very good question. And I think the group that just want it out actually are the group that potentially benefit from that.
Dr. Karin?
Matt, as always, a great talk. And, I think the data your consortium gathers is as impactful as what the Danish studies have been. So, it's really welcome. Yeah, I'm going to ask you a little bit of a topic you didn't touch on, and that is, does the possibility of a cochlear implant post-acoustic neuroma surgery change this thinking? Or in the next 10 years, do you think that that will impact how we think about when to intervene?
Yeah, awesome question. I do think it will. Just some statements about cochlear implants and vestibular schwannomas. Obviously, the first thing is with single-side deafness, there's been a lot more attention to it, and also the added benefit of tinnitus suppression. Some of our patients with vestibular schwannoma will say, just give me the treatment that's going to get my tinnitus to be gone. That's actually like their question. And cochlear implants have that ability for a large number of people with vestibular schwannomas, and you can rehabilitate unilateral hearing loss. Then a number of people with a unilateral vestibular schwannoma are 70 or 80 years old, so their hearing loss from their vestibular schwannoma is compounded by presbycusis or early life exposure to noise and things like that. So there's going to be a lot of people who are older who are qualified for audiometrically. Medicare still has an exclusionary criteria for a presence of a retrocochlear lesion. But I think it's going to change over time, and more people are going to undergo the treatment. Just some general statements. If you have an observed tumor, so we just published a multi-center series of 100 people with sporadic vestibular schwannoma that underwent CI, and the punchline is it was reasonably even between the number of people at microsurgery, observation, and radiosurgery. If you have an observed tumor and it hasn't grown for a period of time, or if you have radiosurgery, you have, with those two situations, you have a 90% chance of achieving open set speech perception. There's a range of performance, but achieving open set speech perception from your CI. With microsurgery, it's the flip of a coin. It's perfectly 50% or 55% for your likelihood to get open set speech perception. And then I think there's two reasons for that. One is just the selection of people who get surgery typically have a little bit bigger tumors, but more importantly, surgery increases the risk of trauma to the cochlear nerve more than observation in radiosurgery. So I think over time, for people who want the benefit of a cochlear implant, mainly for hearing or sound localization, speech understanding and noise sound localization, or for tinnitus suppression, we'll choose more conservative routes for them, at least initially. Yeah, it's super interesting because now this is a totally different talk, but I love this topic. So now if we're planning on doing a CI and they want to have surgery, so we tell them all those, your probability of outcomes based on observation, microsurgery, radiosurgery with a cochlear implant. If they want to still have surgery, even though it's a little bit lower probability of having the CI work, we put a commercial device at the beginning of the operation on a translab. So we mastoidectomy, decompressed middle fossa dura, sigmoid, and we put a cochlear implant in at that time. We tie the electrode out of the way, kind of do a loose lasso knot, so it's kind of out of the way. And we monitor NRT, which is completely useless. It doesn't change the entire case. And then EABR, so we put ABR electrodes and we monitor EABR for wave 5. And then more recently, we've been using a visual ESRT. So we're doing an ESRT through the cochlear implant and looking through the facial recess and seeing the stapes reflex actually contract. And we found that ESRT is actually quite reliable. There's some groups that are using the MED-EL test electrode, which was designed and released by MED-EL and Luis Lasaleta in Spain in like 2017 or something like that. And like WashU is using it and things like that. So they'll do the case. They'll put that test electrode. It's not a full device, but they'll put the test electrode in at the beginning. And if they preserve EABR, then they'll put a real implant in. And I've always said, well, you don't know what you don't know. What if your EABR goes out? You withheld the treatment from a person who could benefit from the implant. So we keep, until we know more, we just leave the commercial device in there, even if our ESRT and EABR go out. And what we found is that ESRT is more reliable than EABR in determining who's going to have a good outcome. But all those, sorry, I just kind of got on a side tangent of something that I'm really excited about. I think is really cool. But I think it is going to change how probably the allocation to microsurgery, radiosurgery, and observation. I also think it'll, like if we're doing an approach for a translab, even if we're not putting an implant in at that time, I think in the future, we're going to monitor the nerve and leave a spacer in there because when they're 40, they have the surgery. And when they're 60, they want a device because their other ear went down or whatever. I think there's going to be a lot of developments over the next 15, 20 years related to that.
I know it's 6, but there are more questions that are still coming in. Ali Benedetti, member of our audiology team.
Hi. So I have a question kind of from a perspective of an audiologist, and it's more so of how the patients are impacted by the knowledge of that they could lose their hearing completely, and also might not have the option to get a cochlear implant if the nerve is severed. How that impacts their decision making for treatment.
I mean, very much so. I mean, we have a similar to Hopkins and Mass General and other groups. We have a multidisciplinary NF2 clinic, and that conversation comes up even a lot more in that population than the sporadic group, but it's certainly very relevant to both groups. We just if you only have one ear or the other ear is very, very threatened, you have to be very careful with what you do with that one ear. And this is very controversial. And this is a whole nother discussion that could be a whole hour-long or day-long discussion. But we're more likely to radiate, which I know people are going to gasp, but we have good reason for it. A small or medium-size NF2 patient, particularly if the other ear is dead, because the CI is much more likely to work in them for a much longer time than just doing the surgery. I think it'll be interesting. So right now, when we resect a tumor, we'll use the facial nerve monitor to determine if we should perform subtotal resection, because we're trying to preserve the facial nerve based on the premise that facial nerve testing is pretty accurate. It's not perfect, but it's pretty accurate. We don't perform subtotal resections for cochlear nerve preservation most of the time, mainly because monitoring is not very exact. But I do think that there's a day that if we can monitor the nerve health better, that will actually perform tailored subtotal resections for hearing also, particularly when it's your only ear in an NF2 patient or something like that, and potentially radiate the remnant and give them a cochlear implant. In the NF2 population, that comes up all the time, what you just asked. And in the sporadic group, it still comes up sometimes. Actually, I got a message today from a patient who we saw 2 weeks ago who has a growing tumor. I think it's like 1.2 or 1.3 in the angle, and she's deciding between radiosurgery and microsurgery. And she wanted it out, but she also really likes the idea of having a functioning implant, even though her other side's okay, her hearing is. And she's actually leaning towards radiosurgery now, even though she came in with the notion of having surgery just because of that 55% versus 90% chance of having open set speech perception. So it's super interesting, and it definitely can tip people different directions just based on that knowledge.
We got one last. Oh, great. One last question from a member of our audiology team, Dawn Marcelia. Can you join? And unmute. Great. I don't have your audio.
Well, the audio coming up, Dr. Carey, I couldn't help but notice your Max Brodel pictures behind you. I have the same ones up in my office. They're pretty cool. Mayo Clinic actually tried to steal him from Hopkins. We were unsuccessful. We have another early illustrator at Mayo because we couldn't get Max Brodel, but
I couldn't help but notice our Johns Hopkins centennial tie around.
yes.
Thank you.
Yeah. Thanks for noticing.
You've worn it more often this year than I have.
Dr. Marcelia is having a hard time joining audio and video, I think, but she texted in her question, which is in counseling her patients as an audiologist, at what point does tumor size typically cause hearing loss? That's her question.
I love that question. So for a lot of reasons, but we always naturally believe that the reason a person has hearing loss is because the tumor is pressing on the nerve and it's a compressive injury. But what's super interesting is we've all seen the patient with a 4-centimeter tumor has totally normal hearing or maybe just a slight decline, and the patient with an IC tumor that's 2 millimeters and has complete hearing loss. So there's a very, very loose correlation with tumor size and hearing, which begs the question, what's actually driving hearing loss in vestibular schwannoma? And there's 4 or 5 different theories. One of them's compression, one of them's vascular change, one of them's dumping proteins. One of them is poor circulation of fundal fluid and cochlear fluid. So it's a super interesting topic. We don't understand that very well at all. Actually, the drivers of hearing loss in vestibular schwannoma.
Terrific. I think that brings us to 7 minutes after we're going to have to bring our session to a close. I see Scott Young and Ginger Grant are also with us. And Mr. Young asked me to convey thanks of the Young family to our speaker, Dr. Carlson, and to all of you for joining this vibrant discussion. I think it was great. And thank you for helping us honor the memory of Karin Young and John Niparko.
Very grateful for the opportunity. Thank you.
Thanks, everyone.
Thanks, Matt.
For all the